Okay, we're going to talk about some aortic aneurysms with the concept of perfusion. And there are two types that we're going to talk about. Chapter 30 in your Med-Surg book on page 862 through 867. That's where you will find this information. So let's talk about some common arteries just for part of review. And in this, you will see carotid arteries, left and right, subclavian, which when you are working with central lines or multilumen catheters, it's also called the SVC, brachiocephalic artery. Then you have parts of your ascending and descending aorta and the aortic arch. Then you have your abdominal aorta, which is below your kidneys, and the right common iliac arteries. So areas of that I wanted you to pay close attention to, and the first one we'll talk about is the aortic structure. It involves the aortic root. You'll see this right here at this very bottom, and it's included in that is that valve leaving from the left ventricle out the aorta. So then you see this part, and it's called the ascending, going up the aorta, then the aortic arch, and then the descending thoracic aorta. So those are important parts to remember, because this is where you're going to see and can see any part of a thoracic aneurysm. Talk about aneurysms shortly. So let's talk about the structure of an artery. There's layers of an arterial wall. You'll see them listed on your left. And tunica externa in your book is also called tunica adventitia. Tunica media is known as just it is, and then tunica intima is also seen on this slide as the tunica interna. And that tells you the different layers of your arteries. So when we talk about arteries and their layers, the intima layer is the thin, delicate layer where blood flows through. It's the innermost layer. So then the tunica media is very strong and allows the artery its strength and elasticity. Tunica adventitia is the outermost layer of the artery. And all aneurysms involve a damaged medial layer. And when the medial layer weakens, adventitia begins to swell and forms the aneurysm. What's an aneurysm, Ms. McHargue? It is, according to your Med-Surg book, a permanent localized dilation of a blood vessel, meaning your artery. It is a weak point in the wall of an artery, and an aneurysm is 1.5 times its normal diameter. So that means that artery has enlarged. As I said earlier, it's a weakened portion of the aortic wall. I'm going to ask you a question, and in your notes, you can make this a question to remember. Is what wall did we just say weakens and forms the aneurysm? So in that first picture that we looked at, we saw the ascending, descending aortic root and aortic arch, and then we saw the abdominal aorta. These are the areas you will see aneurysms form. Pathophysiology is the damage to the middle layer of the aorta. There's the answer to your question. But what you need to realize is once an aneurysm develops, the trend for that aneurysm is to grow and explode, I may say, or bleed out. So we can talk about several different etiologies on aneurysms or why they're formed. That is in your textbook on page 862 in the chart 30.6. Congenital aneurysms form from connective tissue disorders. Abe Lincoln had an aneurysm, but that's not what killed him. And he had a connective tissue disorder called Marfan's disorder. And another etiology is the mechanical. That's where the arteriovenous fistula forms. It can be related to an amputation. A traumatic aneurysm can form from a penetrating injury to an artery or a blunt injury to a chest trauma. And these are also known as pseudoaneurysms. So with an aneurysm and this type of aneurysm in the traumatic category, think of a motor vehicle accident and the person is the driver and gets T-boned on the driver's side. It torques that aorta and it can shear it and tear it, and then that thus causing it to rupture. Then there's an inflammatory type etiology, and those are the non-infectious type associated with arteritis, systemic lupus, Kawasaki's disease, and sometimes in pancreatitis. And then we have the infectious etiology, and that's also known as mycotic. It's related to bacterial and fungal infections, can cause an aneurysm in that artery. Aneurysms can be related to pregnancy, and then also anastomotic type aneurysms. And that's after a post-arteriotomy, when an artery has been opened, either grafted because of an infection or an arterial wall failure, the sutures tear or they fail and the graft fails, causing an anastomotic aneurysm. So those types again, congenital, mechanical, traumatic, inflammatory, infectious, due to pregnancy, and also anastomotic type aneurysms. So if we classify aneurysms in the aorta, there's two basic classifications. One is a true aneurysm and the other is a false aneurysm. So when we talk about true aneurysms, it includes the wall of the artery that's forming the aneurysm, at least one vessel layer still intact. And the two types, and we'll go over all the types of aneurysms in the next couple of slides, is the fusiform. These are the two most common. It's a circumferential, relatively uniform in shape, and a saccular type that's a pouch-like, a narrow neck connecting the bulge to one side of the arterial wall. Now, that one can be localized, and the fusiform can be diffuse dilatations on the aorta. And just remember that on the fusiform, it is the entire circumferential area of the artery. A false aneurysm is when the blood vessel leaks through the wall of the aorta and contains by the surrounding tissue. So sometimes these aneurysms put pressure on other organs, so the organ becomes its way that it tamponades within itself. It keeps it from growing larger, but then sometimes they don't. They will grow larger in other times, causing pain and related organ issues. Faults aneurysms can affect all three layers of the aorta. So let's look at those pictures of types of aneurysms. So in the first picture A, you see a normal artery. Remember those three layers, the adventitia, the media, and the intima. So in B is a faults aneurysm. You see the sac sticking out on the outside, involving only two layers, where the sac is on the outside of the first layer. C is a true aneurysm. It involves all three walls. And we would call this one, we would call the next one C. Let me back up. C is the true aneurysm and D is the fusiform. Remember the sac-like is on both sides circumferentially. And then the saccular, you see the sac in itself. And then F is the dissecting aneurysm. And we'll talk about dissecting aneurysms at the end. Different types of aneurysms. Aortic aneurysm in the thoracic region. So note here the anatomical regions in that area. So the aorta roots itself from the left ventricle, where blood is ejected from the left ventricle out the aorta. Lots of pressure, lots of squeeze. And looking at this picture, 70% of all cases of thoracic aortic aneurysms are caused by atherosclerosis. That's something for you to remember. They occur most frequently in men in the ages of 50 to 70, and they do and will occur in women, but later in age. It can involve just the root, or it can involve any part, ascending or descending, or the arch. There's some videos attached to these PowerPoint slides, and they're very informative, very interesting for the visual learner, for all of you to watch. So risk factors along with atherosclerotic changes in the artery is smoking. Thoracic aneurysms are also called TAAs, and they are the most common site for dissection. Signs and symptoms for nursing to look at will vary depending on the state and the rate of the development of the aneurysm and how the pulsatile mass affects the surrounding organs. Remember earlier I said they can grow in size and put pressure on surrounding organs. Some clients are asymptomatic, but most prominent symptom for those that are symptomatic is pain, described as a constant, boring type pain when the client is laying supine. When these aneurysms form on this thoracic aneurysm aorta, my words are not good. So when these aneurysms form on the area in the thoracic region, because of the type and location anatomically, it can cause aortic insufficiency. Pressure from these aneurysms can cause, if putting pressure on specific organs, shortness of breath, pressure on the lungs, dyspnea. It can also put pressure on the nerve roots, causing hoarseness, laryngeally, a cough from the pressure, stridor to the voice box, and weakness to the voice box, making the patient or the client have trouble swallowing. So remember, shortness of breath, dyspnea, hoarseness, cough, stridor, and weakness are all things for nursing to look for in these thoracic aneurysms. Sometimes you will see folks, when you're assessing them, the superficial veins in the chest, the neck, or the arms can be dilated because there's a lot of pressure behind all of these aneurysms. And some folks, you can see cyanosis on the chest wall. And it's been known for these aneurysms to put so much pressure on the cervical sympathetic chain and the cervical vertebrae and cause unequal pupils. So when you assess a client and you see unequal pupils, you need to make note of it and let the provider know. How do we diagnose these? And I was going to say unfortunately, but fortunately for some patients, on a normal chest x-ray, not to look for the aneurysm, but just because they need to have a chest x-ray, they're incidentally found. And then they need to have what's called a CTA or an MRA, which looks at the arteries. And a simpler procedure that can be done at the bedside or in the cardiac cath lab is a TEE, a transesophageal echocardiogram. They go down the esophagus and they look at the walls of the heart and they look at the valves. And they also can see the aorta and the aortic valve, the aortic root and the aortic arch, ascending and descending, and they can see where the aneurysm is. Treatment we'll talk about here shortly because treatment is kind of based on other things. So let's look at the other area that aneurysms form, and that's in the abdominal cavity. So note here the heart, and then you have the descending aorta coming down below the heart. Then we, of course, have the kidneys, but know this, that below the kidneys is usually where the abdominal aortic aneurysms form. So if this area swells and gets larger, which organ is it going to put pressure or decompensate? I'm going to use that word. So think about that one. So abdominal aneurysms are also known as AAAs, or you'll see it abbreviated as AAA in capital letters. They mostly occur below the renal arteries, and they are 4 times more common in men than women. They're more common in Caucasian men. Risk factors, here again, we're hearing the same thing. Smoking, atherosclerosis, age, older folks, and hypertension. Now, my question to you is, why is it age determined that we see aneurysms form? And also with hypertension, why do we see aneurysms form? Think about those, look up that material, and as of questions of the day, I will post answers. Signs and symptoms, abdominal aneurysms. So some folks complain of back pain. So note, they can grow anteriorly, they can grow on the sides, and they can grow posteriorly. So if they're growing posteriorly, they can put pressure on the lumbar region and they can cause back pain. One of the things that people note most with abdominal aneurysms is the pulsatile mass on the abdomen when the client is laying supine. And sometimes you can see it and they don't have to be laying supine, but it is something that you will never forget. You will see the abdomen pulsating in this area, and you will also be able to lay your hand on that area, and that aneurysm will move your hand as you are touching the abdomen. Thrombus can form in this area because you've got a swollen area, and above and below, you don't have the force. It's either constricted or dilated. So things don't move up and down the way they should. So therefore, if a thrombus can form in these areas, we're thinking about clotting off other organs distally or proximately, i.e. the kidneys. And if they clot off distally, they can cause circulation, no circulation in the distal extremities. So nursing needs to note very, very important, the pulses in the feet, lower extremities of their clients, especially if they have an abdominal aneurysm. Now, the other thing that you will note nursing can do when you are assessing abdominal sounds, when you're doing your routine assessment, is a systolic bruit heard over the mass. So if you know where the abdomen, you know where the aortic aneurysm is in the abdominal cavity, you can lay your stethoscope there where the pulsation is that you have felt, and you can hear a bruit. For those of you who have never heard what a bruit sounds like, when you go to dialysis, ask them to let you lay your stethoscope on the AV fistula for where they do dialysis, and you'll hear what a bruit sounds like. A bruit sounds like a swishing sound underneath your stethoscope. So remember, dialysis, to hear a bruit, and then you'll know what a bruit sounds like. Now, when these aneurysms rupture, the client is in trouble. They have severe back pain or abdominal pain, depending on which direction the aneurysm is growing. And it can put compression on the lumbar region and cause paralysis. So hematomas can form, causing leakage into other organs and lower abdominal cavities. And I don't know if you guys have heard this yet, but you will be able to realize and understand how much fluid, blood, the abdominal cavity or the retroperitoneal space can hold. And that's up to 2 or 3 liters. A lot of blood, a lot of time that you don't need to waste and this patient doesn't need to lose. Medical treatment for an aneurysm. If the aneurysm is less than 5 centimeters, whether the client is symptomatic, treatment for this aneurysm depends on the size, less than 5 centimeters. If the client is symptomatic, they need to go be evaluated by a healthcare provider who is a neurovascular physician, because that is who will take care of the aneurysm. So they will watch the aneurysm and to make sure that it doesn't increase in size, it doesn't cause any injury to any surrounding organs, it doesn't contain a dissection, and it doesn't involve any other branched off vessels. If they are not symptomatic, we're going to do the following things listed here on the slide. So we want to make sure that they are compliant if they need to be put on antihypertensives. And that is nursing's part, to educate your client about compliance and antihypertensive medications. The reason you're putting them on there is that you want their pressure to go down. Did you think of that? Every pulsation that aneurysm has is another risk for it to explode or burst. So we're going to talk about the beta blockers. Types of beta blockers that you will see used with these folks that need to be put on an antihypertensive is atenolol, metoprolol, and carvedilol. These are just a few, doesn't mean it's just those 3. Any beta blocker will do, but you will sometimes see the ones that I just mentioned. If they are not tolerable to beta blockers, then you will see the providers order the ARBs. So those examples could be losartan, valsartan, or irbesartan. Doesn't mean it's just those 3. It can be any of the ARBs, just giving you examples. We want to keep their systolic blood pressure between 90 and 120. The best for them is less than 120 millimeters of mercury. And if they're being seen by their provider on a routine basis, then we want to make sure that we note what their MAP is, their mean arterial pressure, and that needs to be between 65 and 75 millimeters of mercury. Most people don't even look at that middle number in parentheses because they don't know what it means, but you as the nurse or the healthcare professional will note what that number is, 65 to 75 millimeters of mercury. If you're working in critical care, I can tell you more than times than many that families will come in and they'll say, well, what's that number mean in those parentheses? So if we have a stable aneurysm, antihypertensives come into play and we need to keep that blood pressure down. So when I say stable aneurysm, I mean it's not growing, it's being watched, blood pressure is stable with medicines, and they're not hypertensive. You do not want these folks hypertensive. So the other rule of thumb with antihypertensive medications are you want to keep their diastolic blood pressure less than 100. 80 is best, but here again, if they're greater than 100 millimeters of mercury diastolically, the risk for a rupture is higher. So the goal of controlling medical treatment for these folks is to keep them stable, to keep their blood pressure under control, to keep their anxiety under control. What happens when we become anxious? Our blood pressure goes up. Control risk factors, atherosclerosis, smoking, things that we can take care of ourselves. So that's why you will see anti-anxieties on here, medications for folks that may need them. Then we also see that niacin, Mevacor, and statin are ways to get rid of the atherosclerotic issues that this client may have. AAA treatment. That AAA means abdominal, and it also means that we're going to look at our thoracic aneurysms as well. But in this slide, AAA means that if we have an abdominal aneurysm that's greater than 5.5, and nowadays you will see it 5 to 5.5 centimeters, that neurovascular surgeon provider is going to be looking at this client more regularly. They're going to look at it so that we know the size. Is it growing? Is it getting changing? Is it have an area of dissection? We need to know all of those things. So if we think of 5 centimeters, that's 2 inches. So if we have to do surgery, remember that repairing an aneurysm is to restore vascular continuity with a graft. So pre-surgery, nursing needs to do an assessment, a thorough assessment on this client. You need to note what their heart sounds like, what their pulses are. Do they have edema because their aneurysm is big and their fluids and their blood supply can't get back to the heart because of the aneurysm? We need to know cerebral, neurologically, are they intact? Are they having issues? Pulmonary, we need to know what their lungs sounds like. And renal, are their kidneys functioning? Are they compromised because of this abdominal aneurysm? So in the pre-surgery workup, we have to assess for possible rupture, assess for size and involving organs. The provider will do all of those and order the test appropriate to check those things. Ways to fix this aneurysm is endovascular EVAR stents. Endovascular repair is done femorally through a cut down in the femoral artery, and then a stent graft, yes, I said stent graft, is inserted inside the aneurysm place under radiological assistance. And when they do these, you'll see in this video, Abdominal Aortic Aneurysm, YouTube, that when they put this stent graft in place, the stent, yes, helps keep that area open, but the graft attaches itself inside of that artery. So nursing care with the endovascular stents is these folks are going to come back to you with bed rest time. They're going to have to lay flat for 4 to 6 hours after their procedure. Now, if you have someone that has a lot of back pain, you may want to think about how their positioning is and how you're going to keep them compliant with laying on their back for that amount of time. And because it is a femoral cut down area and you will have a dressing, then you're going to look for signs and symptoms of bleeding around that cut down area. You can raise their head of bed after 2 hours, less than 45 degrees. So no more than 45 degrees. 30 is best, but between that degree of 30 to 45 degrees and no more than 45 degrees. These folks during their bed rest time, they're going to have to use a bedpan, a urinal when possible. You're going to be doing frequent vital signs on these folks. Q15 for the first hour, Q30 for the second hour times 1 hour, and then Q1 hour thereafter, as long as your client remains stable. If they're not stable, then you have to do frequent vital signs. Again, we're going to assess that area, the site for bleeding. We're going to look at distal pulses. Cardiovascular and neurovascular assessments are important with these EVAR folks. The reason being is we need to know that the heart's working the way it is, the blood pressure is down where it needs to be, and neurologically we're still intact and there's nothing been flicked off and gone to the brain. So the other thing, because I mentioned the word graft, our bodies have a tendency to reject things when there are certain things put in the body that are not supposed to be there. So we need to be mindful and to educate our clients about post-implantation syndrome. This can happen up to 24 hours after the procedure. When we see this, you will note an increased white blood cell count, a fever, and a decreased platelet count. And this is a sign that the body is rejecting that graft that has been placed. Nursing needs to encourage PO fluids. Why is that? Because they've had a procedure, they've had some dye, and they need to wash out the kidneys or clear out the kidneys. They're going to be getting IV fluid, so you want to make sure that you have a patent IV and you're able to give fluids through it. And we need to monitor eyes and nose very carefully. So, Ms. McHargue, what complications can EVAR procedures cause in patients? They can bleed, they can get a hematoma at the site, they can have a graft rejection or infection, they can have distal ischemia or even embolus, and they can also, at the site where they went in, they can have a dissection of that artery. So graft areas can form embolus as well. They can tear or they can even migrate. So the other thing in your assessment when you're doing them on these folks is you want to make sure that they have bowel sounds and no bowel ischemia. So the new way to fix AAAs, abdominal aneurysms, is through a laparoscopic procedure. So EVARs can be stents in the abdomen and the thoracic. Laparoscopic procedures nowadays, even at Iredell, wherever you worked before and practiced as a nurse, they take them to the OR, laparoscopically use the equipment that they need, and they make tiny incisions, no big incision for the abdomen, and they put a synthetic graft in place. So with this type of closed procedure or a laparoscopic procedure, it decreases the amount of time the patient has to stay in the hospital. It decreases the time of recovery. They're able to get up more quickly, lowers the incidence of limb or organ ischemia, and they can go home a lot quicker. You know, you have some of your folks that want to stay in the hospital or need to stay in the hospital, but then you have those that are sitting up on the side of the bed waiting on you to get out. So also with this type procedure, there's a decreased mortality rate, but there is always a but in some circumstances. Not everyone is a candidate for this laparoscopic procedure. So let's talk about the open with the midline abdominal incision procedure. That's the original way that they used to fix and still sometimes fix abdominal aneurysms. And these folks are going to be your unstable folks. These folks are going to have the larger aneurysms that they have to fix. Lots of pre-work for these folks, because sometimes these folks have a lot more comorbidities than the other folks that we were just talking about. So in the old way, I say, of an open procedure, you get an abdominal incision that goes from your xiphoid process to the top of your pubic bone. And during this time, they pull your intestines out, keep them moist, lay them to the side or to your lower pelvic region, and they go through your abdominal cavity and they find your aorta. And they cross clamp this aorta and they fix the aneurysm either by removing the plaque or grafting around the area of the aneurysm. So some of the pre-op assessment is still the same: pulses, cardiac, neuro, belly, all of that. But these folks are going to need extensive post-op critical care. When you open up a midline abdominal aneurysm and you're fixing it with a big open incision, you have lots of risk for paralysis because of the cross clamp, kidneys to shut down. Remember where the kidneys are to that aneurysm, losing lower extremities. So not only are you extensively monitoring them post-operatively, these folks are going to be on all kinds of drips, all kinds of medications to control their blood pressure. So some of these medications I'm going to mention to you, drips like nipride, nitroprusside, is the same thing, works quickly to get the blood pressure down. It's a rapid onset, it's short acting, it goes quickly. And this is to maintain that MAP 65 to 75 in your patient that has an A-line, more than likely when they come back from OR. And you're also going to see medications to keep the blood pressure up if they're hypovolemically unstable. These folks have a longer hospital stay. They require more education. They have to have multidisciplinary teamwork. They have to have someone to help them get up, out of bed, PT. So remember that there's a huge difference between these three treatments: endovascular, laparoscopic, and then the open surgical abdominal incision. So watch this video, abdominal aortic aneurysm. It'll take you through the surgery. No, it doesn't let you see inside the belly. Picture here, I'll let you see inside the belly. With the surgery, you'll see where the aneurysm is on the picture at the left. And on the picture at the right, you'll see them where they're putting in the stent. So nursing needs to know, what are you going to assess on your client? How many systems are you going to assess? What's your vital signs going to be like? when you get them back in all three procedures. And then you will need to know what education. I've just mentioned all of those, so you need to know those. Here again, in any one of these procedures, these folks can bleed, they can form hematomas, they can form dissections, they can form infections in the graft and rejections in the graft. They can have distal ischemia and the proximal, not proximal, but distal regions of the legs. Thrombus can form because they've been in the OR, they've been opened up. So, and then they can have bowel ischemia. I remember in the very first part of my career, we used to get these folks back all the time. And they were the sickest of the sick and the most unstable patients that came to critical care. So that is the treatment for AAA. The treatment and way that they're going to fix the thoracics is usually through the endovascular way. So how are we going to prevent an aortic aneurysm from happening? Well, nursing comes into play. So we're going to prevent atherosclerosis. What can you teach your client to prevent and how not to get atherosclerosis? Some folks you can and some you can't, but the folks you can is dietary, exercise, low cholesterol, diet, tell Jimmy, treat and control hypertension and maintain compliance, and follow-up appointments. These folks need to go see their providers post-operatively. Aneurysms can form again. So educate, educate, educate. What happens if we don't go to surgery and we haven't had this aneurysm fixed? It becomes unstable and it ruptures. So there is rupture, sign of ecchymosis. It's a triad of symptoms, which includes back pain, hypotension, and a pulsating mass. So when you suspect that you have an impending rupture on an abdominal aneurysm, these folks have severe impending rupture, have severe back or abdominal pain. They complain of low back pain that is severe, and it causes a lot of pressure if it's a posterior growth on the lumbar nerves. If it's growing anteriorly, then folks you'll see the pulsating mass, and sometimes you can see that ecchymosis out on the abdominal wall. Just remember to assess for thrombi and renal failure for these folks if you have a rupture symptoms. So abdominal aortic aneurysms in this picture, the top picture, doesn't really show the aneurysm, but a normal aorta to the left, an aorta with abdominal aneurysm in the middle, and to the right, we have a rupture. When these rupture, it is a medical emergency, a surgical emergency, medical and surgical emergency. These folks need to get to the OR before it ruptures, realistically. When they rupture, they have serious complications related to the untreated aneurysm that they didn't go get checked out before it happened. Posteriorly ruptures, you'll see bleeding, may tamponade around the surrounding structures because of the pressure, thus preventing exsanguination and death. Once they open up that cavity, that's when they blow. Severe pain, we talked about that, and they may have or may not have back or flank ecchymosis. If they rupture, you will definitely see that ecchymosis. If they anteriorly rupture, it's a massive hemorrhage. I've seen folks who have ruptured in critical care who bleed out in front of your eyes, and we can't get them to the OR fast enough. And their from their chest to their pelvic bone, hip bones in front, you will see it will rise up an inch or so off all that tissue off the wall of the patient. These folks usually don't survive if it ruptures. We're saying it's an emergency, urgent, surgical, get them to the OR before we have trouble. So an aortic dissection, what in the world? Another emergency. So think of as the heart contracts with each systolic pulsation, each time that heart squeezes that blood out of the heart to the rest of the body, an increased pressure, it damages areas of the aorta, further increasing a dissection. This may occlude major branches of the aorta, cutting off blood supply to the brain, abdominal organs, kidneys, spinal cord, extremities, so on. People who are at risk for dissection are the folks that we talked about etiology earlier, Marfan's syndrome. They're at high risk. More common in men than women, atherosclerosis, tearing the intima layer down to the medial layer. Risk, folks that are high risk for aortic dissection are cocaine users due to the increased force from the left ventricle, hypertension, and blunt chest trauma. Pathologically, aortic dissections tear at a proximal portion of the aorta. They tear, they rip open inside the artery itself. And as the blood circulates, it tears even more and creates a false lumen or a channel for it to tear even further. And that's where you get problems with other branches branching out, because that's where the blood will go. So looking at the next picture, let's talk about a dissection a little more. Manifestations of an aortic dissecting aneurysm include abrupt, severe ripping or shearing type pain. It's a tearing pain because that's what's actually happening to the artery, the aorta. And mildly or marked hypertension in the early phase. And where does the blood pressure go when all this starts to shear and tear? Because you're bleeding out, you become hypotensive very quickly. If and when this dissects, your pulses will become weak or absent because the blood, you are just hemorrhaged. And you'll lose your blood pressure, you'll lose your pulses in those areas. Syncope. Why syncope? Because you have no blood circulating around in your body. It's all in your abdominal cavity or your chest or retroperitoneally. So it also causes ischemia, as it says here, to other organs. Your patient can have a heart attack because the blood supply is no longer there. They can be in heart failure. They can cause cardiac tamponade and all kinds of other problems. Again, I'm going to repeat some things that are very important for you. Signs and symptoms: severe ripping, tearing, shearing pain. That's because the vessel, the artery itself, is shearing apart. Pain either if it's thoracic in the chest, anterior, and or the back if it's on the posterior side, and it may even the pain extend up to the shoulders. These folks become tachycardic very quickly because they're bleeding. Hypertension at first because of the anxiety due to the pain, and then it will decrease very quickly. So if you have time, which you usually don't, there can be some procedures done to diagnose a dissecting aneurysm. But when you see dissection of an aneurysm in the artery or aorta, you got to think time because you got to work fast. They can do an arteriography to see the extent, the length, how big it is, chest CTs or abdominal CTs to take a quick look and see the size as well. If you can't get there, TEEs, but you have to be careful sedating these folks because they will crump on you very quickly. Echocardiograms, just to look as well. A big sonogram that you can look inside the chest. MRAs, if you have time, but I'm saying to you right now, with dissections, you do not have a lot of time. The other thing that you need to think about with dissecting aneurysm, aortic aneurysm, thoracic aneurysms, is these folks present with such chest pain sometimes, you need to quickly do a 12-lead EKG and rule out a myocardial event. Chest x-rays will show a widened mediastinum because the aorta will be wide. And then, of course, you'll need your labs, CBCs to check your hemoglobin, hematocrit, and your white count to see if there's any infection that it's causing this problem. Nursing, when you are assessing the heart, when you are listening for that lub-dub sound, you hear something different, you could possibly be hearing a loud aortic murmur or your thoracic aneurysms. You're going to check the peripheral pulses. If they're weak, you need to find out why. You're going to monitor their blood pressure. Remember I said it's high at first because they're anxious and they're scared because something's causing them so much pain, but then you're going to lose that blood pressure very quickly. And I do mean quickly. Aortic dissection, collaborative care. You need to get as many people in your boat as possible. You need that surgeon. You need those people who know critical care. But the initial goal is to get that blood pressure down cautiously to make sure that you don't have any myocardial event because you need that heart pumping and contracting, but you need to decrease that heart rate and the blood pressure so that you're not causing problems, but you have to be careful. So the other thing is with these folks is that you have to also decrease their pain. As you are decreasing their pain, you need to think blood pressure. How much can I give them? Am I going to decrease their blood pressure as I give them pain medicine? Sure, you will. The other thing you need to think about is IV beta blockers. So one of the ones that you can give IV, an example, is Esmolol, Brevoblock, and that will decrease, quick act, quick get it down. It will act to get that blood pressure down quickly. Other antihypertensive agents that you may use and see are calcium channel blockers. Sodium nitroprusside we talked about earlier, and that medication, quick act, quick get it down, short act in the body, and if angiotensins come in next to play. What did I say earlier where we need to keep that diastolic pressure? Diastolic pressure needs to be less than 100. If it's greater than 100, then you have to assess your client that there could be a possible rupture. With aortic dissections, it's a surgical emergency. So medications need to be taken in which ones that you use into high consideration of what could happen when you give it. You have to think of the complications that this aortic dissection can cause. Heart failure, extremity loss, death even, occlusions of other arteries. Surgery may be needed, may need to be delayed to allow edema to decrease for permanent clotting of the blood. So when you have bleeding, and you'll get into this because you're going to study DIC, dissecting aneurysms are not a need to wait. They're a surgical emergency. Allowing edema to go away sometimes isn't the best thing to do, but the edema is from all the blood pooling in the aorta. It may not exploded yet, but it can possibly do that. So we have to watch our clotting time. So think about taking that patient to the OR and their clotting times are off and you're going to fix this area, they could bleed to death. Prompt surgical intervention. I say emergent surgical intervention. The 30-day mortality rate for folks who have an aortic dissection remains still high, up to 10 to 28%. So here you're going to have a video. Videos help you understand. You can see it, see how it works. I've watched them all myself. And then this picture here, you see a tear in the wall right here. And then what can happen is if it doesn't tamponade itself off, or it doesn't clot itself off, or it doesn't move, you're good if it doesn't move. But when it moves, it's going to shear that artery wall all the way open and it's going to bleed out into that area. It'll look like this. All right, other resources for you that help with videos. These are resources that have been passed along. The first video is an aortic dissection. The second video is a thoracic aneurysm. The third video is an abdominal aneurysm. And the last one is how you treat aneurysms. So I'm going to unshare or stop sharing. And we are going to be done with this lecture. I ask and I tell you again, if you have questions about this lecture, you have questions about the ticket, you have questions about anything related to what Ms. McHargue teaches, please contact me. I will do whatever I can to help you understand what we are trying to learn. Have a great rest of the weekend, and I'll see you Monday.